So good afternoon, everyone. It's my pleasure today to introduce Dr. Vege. He's currently a professor of medicine, the director of Pancreas Group in the Division of Gastroenterology at the Mayo Clinic in Rochester, Minnesota. Dr. Vege was born in India. He graduated from Guntur Medical School in 1975. And he completed his internal medicine residency and his gastroenterology fellowship at the Postgraduate Institute of Medical Education and Research in India. He did an additional year of research fellowship at the Memorial Sloan Kettering Cancer Center. And during the subsequent years, he basically rose through the ranks in India, in Mumbai, where he was the head of the medical gastroenterology and also the National Hospital in Mumbai. He was also the GI Fellowship Coordinator for the, in India, the GI Diplomate Fellowship Council, before he joined the Mayo Clinic. So he has been at the Mayo Clinic since 2000 in the Department of Internal Medicine as a consultant and also in the gastroenterology and hepatology, and he has been the director of the Pancreas Clinic. He has about 3.5 decades of experience as a staff physician in academic gastroenterology with a focus on pancreatic disease, particularly in pancreatitis that we're going to hear about today. He has published more than 174 peer-reviewed manuscripts, textbook chapters, reviews, practice guidelines, and is a reviewer for many national and international journals. He has conducted a lot of the international consensus meetings for guidelines on, the treatment of acute pancreatitis. In addition, one key aspect in relationship to our city, Atlanta, he was a member of the 6-member international working group responsible for the Atlanta classification of acute pancreatitis, and I'm sure we'll hear some of that today. So he has done had major contributions in the area of pancreas and pancreatic diseases. Yesterday we had a talk as part of our GI Grand Rounds where he talked to us about pancreatic neuroendocrine tumors, and today we're looking forward to his talk on acute pancreatitis. So I'd like to welcome him and thank you for visiting us.
So thank you very much for the kind introduction. Good afternoon, everyone. It's a privilege for me to be here at this renowned institution, and everybody knows about Emory, and I have been thinking of this day that it will happen sometime, and it's happening now. So I'm going to talk about acute pancreatitis today, as most of the time the people who take care of these patients are internal medicine and hospitalists before the GI people come into the consult service. So this is the area that I've been working for the last nearly 2.5 decades as my research interest. And I bring greetings from the Mayo Clinic, where we had minus 50 degrees just recently. And I know that you have cold weather yesterday and today here too. And this is how it was looking some time ago. And I have some disclosures which do not really apply to my talk today. And some of the contributions that I feel happy that I've been able to do for this field are here, as you can see. One of the important things is the moderately severe acute pancreatitis. That's an entity which we coined based on analyzing many years of experience, and that has been included into the classification. So how big is this problem? I think to know how big is this slide tells you this is the 3rd commonest GI admitting diagnosis according to the United States burden of GI diseases. The annual cost is about $2.6 billion for this disease, about 750,000 ER visits and office visits, both acute and chronic pancreatitis put together. The mortality has come down to 1%, which is good, but the morbidity is the one that's driving these costs, about $2.63 billion, and that's one of the reasons why we should focus more on this. The incidence is increasing. And as you all know, Atlanta and Emory is famous for this particular disease, and that's why I feel very happy that I'm able to spend these 2 days here, because the first classification of this disease, Ed Bradley, who is also a good friend, is from Emory in 1992. And then we revised that after many years because of the developments that happened in 2013, and I was one of the active participants in that particular group. So, according to the new revision, the only thing we changed from what Ed Bradley has done in Emory and Atlanta in 1992 is introducing this new term, moderately severe acute pancreatitis, which is like mild pancreatitis in the sense the mortality is very low. But the thing is, the morbidity because of the local complications is very high, like severe. So that's where most of the money is spent. And that's the main change for the classification, besides many other smaller things. And also the nomenclature has been made more simple because anything which is very complicated is very hard to follow and nobody is going to follow. So if you are coming up with any new classifications or anything, try to make them as simple as possible, because otherwise nobody is going to pay attention. So in the acute stage, you have 2 types of collections. Acute necrotic collection in those 15 to 20% of bad patients, and simple fluid collections in the mild cases, which resolve almost always. And only when they persist after 4 to 6 weeks, they are called pseudocysts. While we use the term pseudocyst all the time, most of the collections that persist with the wall after 4 to 6 weeks are actually not pseudocysts, because simple fluid collections get resolved, and they are actually necrotic collections, which are called walled-off necrosis. Now, this is how the interstitial pancreatitis looks. The whole pancreas is enhancing normally after IV contrast, so there's no death at all. But there is a little bit of fluid here, which is called acute fluid collection. It's not a big one. And you can see that the liver is having fatty liver, because for the residents, the way you diagnose fatty liver is when the liver looks darker than the spleen, which is here, a little bit of spleen you're seeing, that is the fatty liver. I mean, you can calculate the Hounsfield numbers, which are usually 15 to 20, but you don't even have to do that. And an eyeball sign, if it looks like this, it's fatty. It is fatty infiltration of the liver. So this is interstitial mild pancreatitis with a little acute fluid collection. And if that fluid collection persists after 4 weeks and forms a wall, then you call this pseudocyst. You can see that the pancreas is still normally enhancing throughout. But the pseudocysts are not very common, because most of the time the simple fluid collections get absorbed. And the pseudocyst that is used by everybody, the surgeons, radiologists, gastroenterologists, are walled-off necrosis. So this is how the necrosis looks like. You can see only the body here and the tail here is enhancing. Most of the tail and the neck of the pancreas and head, they are all gone. This is necrose, so they don't take up the contrast. And it is also in the peripancreatic area. So this is acute necrotic collection. And if this persists after 4 weeks and forms a wall, like this, the wall, then it is walled-off necrosis. This is in the pancreas. Only a little bit of tail is remaining here. And these are in the peripancreatic area, walled-off peripancreatic necrosis. So the 4 collections are the ones. And MRI is very useful if you label a case as quote-unquote pseudocyst, because on the CT it looks very clear and you think there is no debris, no necrosis. But if you do a MRI, you can see the debris much better. Whereas on the simple CT, you may not be able to see that. So MRI has an advantage. Besides, MRI has 3 advantages for internal medicine residents compared to CT. One is the debris can be seen better. The second one is if they have iodine contrast allergy, then you can use gadolinium. And the third thing is if there is a renal insufficiency, you cannot give gadolinium, you cannot give contrast, then you can still have a good MRCP and MRI with T1 and T2 without gadolinium. And the fourth one is MRI will show you pancreatic duct integrity and the bile duct for stones better. So there are 4 advantages of MRI compared to CT in acute pancreatitis if you have internal medicine questions. So you can see the large amount of debris in this collection seen on MRI, which is not seen on the CT. Of course, you have these gas bubbles. Once you see gas bubbles inside a fluid collection, it is infected necrosis. You don't have to do any fine needle aspiration, cytology, or any stuff like that. The best clinical medicine is when you do least. If you do more because you have things, that's not good clinical medicine. So there are 3 phases of acute pancreatitis. The first one is in the first week, where hospitalists and internists should know more because GI may or may not be involved. The second phase is between second week to 4 to 6 weeks when the complications form and you may have to do interventions. And the third phase is beyond 6 weeks when they get dismissed. But here, we are more worried about readmissions, the development of type 3C diabetes, which is diabetes due to pancreatic disease, acute chronic pancreatitis, and cancer. And also obstructive chronic pancreatitis and exocrine insufficiency. I'm not going to talk about those, but these are the two that we will be talking. So the management decisions during the first 7 days for internal medicine residents as well as hospitalists are identifying the cause, prediction of severity, intravenous fluids, prophylactic antibiotics, urgent ERCP, when to do and who are the people to do, oral feeding in acute pancreatitis, enteral nutrition with tubes, role of total parenteral nutrition, and same admission cholecystectomy. These are the things that you are interested in the first 7 days of acute pancreatitis. And of course, alcohol counseling before dismissing the patient, which is extremely crucial, which we don't do usually. So identification of the cause. Alcohol and gallstones together, as you know, are about 60 to 70%. Then the common causes are post-ERCP. This is where we give the patient pancreatitis, otherwise the patient won't have pancreatitis. And hypertriglyceridemia is very important because metabolic syndrome is an epidemic in this country. Medications, we always talk about it, but it's very hard to prove in a given patient whether that medication is the cause or not. So my advice is, if you can avoid that medication without causing damage, then you can stop it. On the other hand, if there is a medication like statin, which is usually listed as a cause, but if the statin the patient is taking for 2-3 years and you get a pancreatitis, then it's not a good idea to blame that and take away statin because the patient will die of heart attack. So that's the problem. And if you have gallstones on ultrasound and if somebody has pancreatitis, does not mean that those gallstones cause the pancreatitis because gallstones are so frequent. You can only say that those gallstones have actually caused pancreatitis if the ALT is more than 3 times elevated. Otherwise, they may be just innocent bystanders. And as we all know, getting a good alcohol history is very, very difficult. They may not give you the history, but you have the poor man signs of increased MCV and other things, AST-ALT ratio, which can help you that maybe that's the cause. Then continuing the causes, if somebody is over 50 and you don't have a cause, always think of pancreatic cancer as causing acute pancreatitis. The simple way to remember for internal medicine residents, if you take 100 cases of acute pancreatitis, maybe 2 or 3 are because of pancreatic cancer. If you take 100 cases of pancreatic cancer, 2 or 3 may present as acute pancreatitis. So it's always important to keep this in mind because of the deadly nature of the disease. And it's become a fashion to say autoimmune pancreatitis as a cause of acute pancreatitis, but you have to understand it's so rare. If you take 1,000 cases of acute pancreatitis that come over a period of time in any major institution or a province, if you have 1 or 2 of those 1,000 as autoimmune pancreatitis, that's probably what it is. If somebody has idiopathic pancreatitis under 35 years and if there is a family history, consider genetic causes and then try to send off at least 4 genes that we have the ability to test now: CFTR, PRSS1, SPINK1, and CTRC. And if you don't find any cause, which happens in 20% of the patients, then bring the patient back after 8 to 12 weeks when the inflammation subsides and do a good MRCP and endoscopic ultrasound to pick up causes that have been missed earlier. And particularly endoscopic ultrasound can show small stones in the bile duct or small tumors causing obstruction of the pancreatic duct or underlying chronic pancreatitis that is going on for a long time and has come to the surface as an attack of acute pancreatitis. Then the second one is predicting the severity, because during the first day when you see them on the floors, you do not know whether they take a right turn and go into the 80% of the people who just get dismissed in 3 to 5 days. Whether they are in a small town or whether they are treated in Emory, there is no difference. They are all going to recover. So it doesn't matter. But on the other hand, the left turn, they can go into the 15 to 20% who are moderately severe and severe. So they have organ failure, local complications, morbidity, and the need for interventions. But unfortunately, on day one, they all look the same. So for last 20, 30 years, we have been trying to come up with various criteria to say which one goes this way, which one goes this way. Starting from Ranson, who was at Bellevue way back, there have been some 20, 30 scoring systems that have been reported about variety of laboratory markers, clinical predictors. If you start getting a scoring system getting published every 1 year by somebody's name, and they keep coming, that means we don't have a good way to predict. In 2019, there is no reliable way to predict who is going to be having severe or moderately severe. Most of the people say that their system has a very good negative predictive value of 90%, 85%, but that means nothing, as you know, because even with your eyes closed, you can go into a patient's room and say this patient is going to have mild pancreatitis. You are 80% right, because that is what it is. What we need is a positive predictive value. That means the system will tell you with good accuracy, this guy is going to get into the 15-20%. We don't have it. So in the absence of that, we try to throw in as many as possible and try to err on the side and tell the patient and family that this may be a severe attack, that is advanced age, BMI more than 30, high hematocrit, BUN, creatinine, systemic inflammatory response syndrome score, comorbidities, etc. The more that are present, the more confident you are they fall into that 15-20%. But the thing is, even if you predict that they're going to have a severe course, there's nothing you can do in the first 24, 48 hours. We don't have a drug to treat these people. There's nothing special that we're going to do except probably counseling the family and ourselves getting prepared. They may spend a lot of time. That's the problem. So then we come to the intravenous fluids, which is the mainstay of therapy. This is all that we can do for these people. And so we have realized that giving them good hydration in the first 24 hours is very important so that they don't get necrotizing pancreatitis. And the basis for this is hypovolemia here is because of the third spacing. And if you have, the other thing is, if you have intracellular acidosis, there is more tryptic activity. And that's the reason for saying that lactated ringer may be better than normal saline. Then this contributes to renal and circulatory failure, the dehydration, and also microcirculatory problems in the pancreas leading to necrotizing pancreatitis. There are some small randomized controlled trials showing that maybe lactated ringer is better. But when we did the systematic review, technical review for AGA, and that came in Gastroenterology a few months ago, a detailed meta-analysis of all, we are surprised to find that despite all the guidelines where we are saying you have to do this, you have to give lactated ringer, etc., we could not convincingly say anything about the way to give these fluids, which goal we have to use while giving the fluids, what volume we have to give, what rate we have to give, which fluid we have to give, and how long we have to give. We don't have anything. So in the absence of that, we just say 250 to 350 ml per hour, only during the first 24 hours, probably lactated ringer, and using your clinical judgment, you are not overhydrating. That is the best we can go, but really there is no evidence to prove that. So there's a lot of opportunity for people to do trials, and now there is a big consortium trying to do that in the United States, about 12 centers. Then we come to the prophylactic antibiotics. That means you give antibiotics before there is an infection, not after 10 days when they have fluid collections getting infected. It used to be the way that we used to treat, but subsequently, this slide will tell you about this, and you have to use the antibiotics which penetrate the pancreas, and the idea is to prevent infected necrosis of necrotizing pancreatitis. But once again, the meta-analysis has been done, and we have published so many others, that most of the meta-analysis of the recent RCTs did not show any benefit for the prophylactic antibiotics, even in people where you have predicted severe or moderately severe pancreatitis. And we know that we cannot predict them anyway accurately. So right now, most of the guidelines say do not give prophylactic antibiotics unless you suspect clinically infection is going on. But maybe some subgroups with extensive necrosis and organ failure may be benefited. These are the signals that we got in the meta-analysis when we did. But to do a trial and to prove that those two subgroups will be benefited, you have to do a large trial with large number of patients, and I doubt if such a study will ever happen. Then comes the other question: when do you do urgent ERCP for acute biliary pancreatitis? By definition, urgent means within 72 hours, maybe even earlier. That's urgent. Elective ERCP in a biliary pancreatitis before cholecystectomy, that's different. That's to see if there is any residual stone in the bile duct, clear it, and then they take off the gallbladder. That's not what we are talking. Here, mere biliary pancreatitis is not an indication for ERCP, urgent ERCP. If there is no cholangitis, no elevated liver test, it's not indicated for mild biliary acute pancreatitis. This is only urgent we are talking about. And probably indicated for persistent bile duct obstruction with elevated liver tests and dilated bile duct, even if there is no cholangitis. But once again, when you look at the evidence, firmly you can say urgent ERCP is required. Call the ERCP team in the middle of the night or early next morning only when there is clinical cholangitis. But when there is cholangitis, you will do it as an urgent thing anyway, regardless of whether pancreatitis is present or not. So then we go to the next thing. This is very important, and I would like all the internal medicine residents to know. For about 100 plus years, we said NPO for acute pancreatitis. The concept has completely changed. So it's now not NPO, but you have to arouse the gut to see that the patient does not get bad complications. So you have to feed these people. The best way to do it is you just tell the patient, after you admit the patient in the floor and giving IV fluids, tell them whatever you can tolerate, liquid diet or light diet, just keep taking, provided they don't have too much of nausea, vomiting. And this is because it's important to have some food in the lumen of the GI tract so that the gut mucosal barrier is protected. And if that is protected, then the bacteria won't migrate through a defective barrier and go into necrotizing pancreatitis and make it infected necrosis, which is 30% mortality. Then we also have looked at various things, whether you have to delay the feeding versus early feeding, clear liquids to start with or solid, and whether the feeding has to wait till the pain subsides, enzyme normalize, etc. You don't have to wait for any of these things to happen. If they don't have severe vomiting, you can just ask them to take whatever they tolerate, whether it's clear liquids, full liquid diet, or soft diet. And also, the randomized controlled trials have clearly proved this, and then usually low-fat solid diet is what we tell them to take, and so immediate oral feeding with solids is safe, no need for pain and enzymes to normalize. And even when you have necrotizing pancreatitis right at the beginning CT scan and the patient comes, actually a third of them can easily take food and you don't have to go for enteral feed, as is evidenced by all the big studies. So this is about oral feeding, which is very important. So next one is, suppose if they are not able to take oral feeding, then we decide about enteral feeding. Particularly these are the people with necrotizing pancreatitis. Generally, it takes about 3 to 4 to 5 days, A, for you to say they have necrotizing pancreatitis, B, for you to say they're probably going to be in the hospital for a long time, and that's the time when you have to make a decision. And usually when you decide, then comes the question whether nasogastric or nasojejunal feeding. There are some small studies which say that both are comparable and nasogastric is easier to place. But in reality, there are many theoretical advantages of nasojejunal feeding, so that you put the pancreas to better rest and stimulate the pancreas less, the ileal brake mechanism, etc., etc. So nasojejunal is what we normally follow and what we have been recommending in most of the guidelines. Around day 3 to day 5, when you know that they have necrotizing pancreatitis and going to stay for a longer time. And you don't have to go for elemental diets, which are all completely digested, extremely expensive. Semi-elemental formula, which is cheaper, is okay. And there is no advantage. As a matter of fact, there is a study which showed probiotics caused more problems, so there is no need to give probiotics. TPN has no role. The only time you have TPN is when enteral is not being tolerated by the patient and the patient is likely to stay for a long time and you're beyond 7 days, then they need TPN. And TPN is the thing that most centers, even some of the advanced centers, start straight off the bat when they have necrotizing pancreatitis, even now. So that's a very wrong practice. Then the next is same admission cholecystectomy if you have gallstone or biliary pancreatitis. This is extremely important. This is one of the standard of care things, and also probably the insurance companies keep looking at your practice if you are doing this or not, so that you prevent readmissions, which happen in a third of the patient within 6 weeks if you don't do that. Saying that you come back, will do after a few days, they won't come back, then they get recurrent attacks. So I think it's best to do it during the same admission. As you can see, recurrences are 20% within 6 weeks if you don't do it. If you have necrotizing pancreatitis, then you should not do it. You have to wait for 2-3 months because necrosis is difficult to do cholecystectomy. Then you have to probably do biliary sphincterotomy and send them while waiting for those 3 months. And it is safe to do during the same admission before you dismiss these patients, and it's not associated with increased complications. So there is a lot of evidence to say this thing. Less biliary events and recurrences of acute pancreatitis requiring readmissions. This is the Lancet randomized controlled trial. Of course, no mortality benefit, but it's readmissions that you prevent. But one thing that we found in Mayo experience is that sometimes when you have labeled a patient as interstitial pancreatitis based on the first day CT scan, and then you say, okay, we are going to do same admission cholecystectomy. But you need to understand that some necrotizing pancreatitis takes 3 to 5 days to evolve, and it may be evolving when you take the patient to cholecystectomy, and when they are actually having necrotizing pancreatitis on the day of cholecystectomy, which you do not know, then you are adding more insult to the patient's inflammatory condition, and they come back in few days with much more rip-roaring necrotizing pancreatitis, which when we look like that, that is even worse than the regular necrotizing pancreatitis. So if you have a patient who has white count elevated or SIR score positive on the day of cholecystectomy during the same admission with a mistaken diagnosis of interstitial pancreatitis, it's better to repeat a CT scan to see if they now have not developed a necrotizing pancreatitis. And we have already shown in our own experience that if you do the biliary sphincterotomy and send them, then they have less recurrences while they're waiting for 3 months in the case of a necrotizing pancreatitis. Next, we move on to the last thing. It's important to give the alcohol counseling before you dismiss these patients, because if you say that you go to your primary care doctor or we will see in the outpatient, it never happens. The patient goes home and patient starts drinking and they come back again. So the best chance is to start it while he or she is with you in the hospital. Smoking cessation, very important for internal medicine residents. Now it's very clear that smoking is as important, if not more important than alcohol, to cause both acute and chronic pancreatitis independently. Even if they don't drink, smoking by itself is actually a very common cause of acute pancreatitis. So the second phase, then we enter into after a week in those 15-20%. Here, you have infection of the pancreatic and extrapancreatic necrosis. Then we may have to intervene for these collections with various percutaneous, endoscopic, other minimally invasive routes. And then you start having vascular and surrounding organ complications. So walled-off necrosis is the most common local walled-off necrotic collection that persists into 2nd, 3rd, 4th weeks and then may get infected, for which we do the whole bunch of interventions. And make sure that you are not misclassifying them as pseudocysts, and you may have to do MRI and find the debris. And they're sterile in 70%, and in 30% they can get infected, in which case the mortality is high. So when do we intervene these people? We did a multidisciplinary, the first big conference in Chicago, Marty Freeman and I did this thing, and all the people from all over the world actually have come for that one-day meeting, whoever has published a paper on their own, and we came up with the bottom line is, this is where the open necrosectomy, we have just put a lid on the coffin and it disappeared almost. We don't operate on these patients anymore like for 70, 80 years. It has been the mainstay of debridement or necrosectomy. And that's the reason why it used to be predominantly with surgeons. And Ed Bradley is from here. He's the one who described the Atlanta classification. So the bottom line of this thing is minimally invasive route is the one that you need to do. So do not intervene early. This is again randomized controlled trial showed that you have to somehow tide over till 4 weeks or so when a good wall forms, and only then you intervene. Even if the patient is sick, give them antibiotics, nutrition, etc. But don't intervene unless really you think the patient is going to die. Who needs intervention? Not all people need intervention. Just because a CT scan looks bad does not mean you need to do something. Never treat a CT scan, never treat a lab report, treat a patient. So 60% of the necrotic collections resolve by themselves. So do not underestimate the capacity of the body and the nature to heal bad looking CT scans and etc. etc. So masterly inactivity is many times it works. Infected necrosis, yes, we have to do debridement. You see the gas bubbles in the collection or fevers, blood cultures positive. In sterile necrosis, if there is no infection, if there is obstruction of the gastroduodenal or biliary or colonic, then you have to intervene because otherwise they have problems. And sometimes you have people for 6, 7, 8 weeks not eating, having some pain, nutritionally going down, then you are forced to intervene. And when the duct gets disconnected because of necrosis in the middle, then you have to intervene. Otherwise, the distal pancreas has no way to empty the secretions. Then you are forced to intervene. And where should the interventions be done? There's a beautiful paper in Gastroenterology that just like in any other disease, now we know for pancreatic surgery or for cardiac surgery, you see the volumes and then the volumes have good correlation with outcomes in every particular disease that we know of. So for acute pancreatitis, the cutoff came as 120 admissions per year. If you have less than 120 admissions, you do not have the expertise to do all this stuff. And it's better probably you refer to, high volume centers. And the options to treat walled-off necrosis are many. Almost all of them are minimally invasive. Percutaneous catheter drainage, endoscopic catheter drainage, endoscopic transluminal, place a hole into the stomach, go into the necrotic cavity and take chunks of necrosis called necrosectomy. You can also use the percutaneous catheter route, dilate, and then put a scope into that and take off from the flank collections. You can also do it with a video-assisted scope, same thing, called VAD. Then you can also do laparoscopic, but for some reason most surgeons are not very committed to this, so the experience and publications are limited, while it's actually a good way to do. Open necrosectomy, as I said, is almost disappeared, except in few centers. And very occasionally you can treat even infected necrosis who are not too sick with just antibiotics alone. And doing nothing is sometimes possible too. Then there are various endoscopic methods how to do it once you say it's endoscopic and not the other ones. So this can be endoscopic drainage with pigtail catheters, or you can put a hole and go into the necrotic cavity and remove chunks of necrosis. Then you can put multiple catheters in the stomach posterior wall into the cavity called multiple gateways. And you can use endoscopy as a step up. First you do the catheter drainage and then you can go with the sinus tract and then do more necrosectomy. That is a hybrid technique, endoscopic and percutaneous drainage, or endoscopic and percutaneous necrosectomies too. And you can put an expandable stent into the tract here that you have percutaneously, and through that you can repeatedly go with the scope. And the summary of the interventions now is open surgery, very rare, very small. A small group can be treated just with antibiotics without this thing. Percutaneous drainage probably is the commonest minimally invasive route on a worldwide basis, because not everybody will have endoscopic expertise like you have here. So many of the colleagues in Emory GI, they are very good at endoscopic thing. Laparoscopy, stepped up approach, and hybrid. These are all for interventions of those necrotic collections where the indications I have shown are present, and wait for 4 to 6 weeks before you do all these things. So then some of the, I think I'll skip because it's already 12:40. Maybe I would take up some, these are the complications, vascular complications, which are probably not important. Trying to go back. Yeah. So I just gave you an idea of the first week, then the subsequent 2 to 6 weeks, and I didn't go into the delayed, that is after 6 weeks, which are readmissions, diabetes, exocrine insufficiency. But the point is, despite all the research we have, decades of research and progress, we still know very little about the pathogenesis and management of this disease. So it's a very negative or disappointing statement, but that's what it is. So I would probably stop here, and we'll be happy to answer questions, because I see a lot of residents, internal medicine residents, and I think it's a good practice for you just to ask questions. In future life, that really helps. Thank you.
So thank you for that overview. You didn't mention amylase. Do you want to comment on the use of amylase or the non-use of amylase?
So, yeah. First of all, I'm sorry that there are some aspects I may have overlooked, and I apologize. In the laboratory diagnosis, you have to have 2 out of the 3 definition is typical upper abdominal pain, which we know what's pancreatitis pain, 3-fold or more elevation of amylase and or lipase, and the third thing is imaging evidence, MRI or CT of inflammation of the pancreas. And we said that you have to have 2 out of the 3, and I'll tell you why that definition. It's not the best definition, but that's the best we could come up currently. Amylase and lipase are the most important laboratory tests, and I should have had a slide about that. We more and more gravitated to lipase in recent times, although lipase is a little more expensive for the following reasons. A, lipase stays longer elevated, whereas amylase comes down within 48 hours. B, lipase is elevated in less number of conditions other than pancreatitis, whereas amylase is elevated in a variety of conditions. And C, there are certain conditions where amylase is not elevated at all, like hypertriglyceridemic pancreatitis and alcoholic pancreatitis too, whereas lipase still may be high. So we are using the lipase.
You talked about the change in paradigm in feeding is good as opposed to previously. Why is that changed? Because when you feed the patient, that stimulates the pancreatic enzyme. So how come the thought process has changed?
Right. So the thing is, the mechanism or the rationale why we kept the patient's NPO for all these years is the same thing. You may stimulate the pancreas, then it produces more this thing. But then when we balanced it against the gut mucosal barrier getting very quickly, within 24 to 48 hours, you can show the changes if they keep the NPO. And if that happens and the bacterial translocation, if you look at between the two, actually stimulating the pancreas with whatever is actually lesser of the two evils. And infected necrosis is significant mortality and morbidity, so you move towards this particular thing. Then we also found that because they don't eat that much during the first 48, 72 hours, even if you ask them to take, they're mostly taking liquid diet. So that diet is never adequate to actually stimulate the pancreas, but it is still adequate to maintain the gut mucosal barrier. So that's the reason between the two, maybe this is better.
Got a couple off-site questions. First, are there any times you would consider, or is there evidence for against the use of steroids in acute pancreatitis?
No.
It was a quick one. Potentially the second one similarly. This is a medication I've not heard of before. Trasolol, aprotenin. Are you familiar with this medication?
Aprotenin?
Yes, sir.
Yeah, negative trials, so it's...
entirely negative?
Yeah, and prednisone and steroids are actually, they can cause pancreatitis too.
Feedback well received. Thank you so much. That's all I have from offsite questions, I believe.
Yes, yeah, there are two questions. Yes, doctor.
you had microphone.
Can you hear me?
Yeah.
So I'm Jay Freeman. I'm a stranger from across the street at Children's Hospital. But I saw just the one-liner on probiotics. I know there's been a couple of trials out there showing really bad effects, including mortality. But some of our Chinese colleagues have started to look at some of the Clostridiums of Brazil and different species and getting pretty different results. So kind of two questions. One, what is your thoughts on what probiotics can look like in the future for acute pancreatitis? And two, especially in kids, they all come on them. Do you immediately take them off of probiotics, or where do you put that in?
Yes, so the Dutch trial is very important because it's a very properly conducted trial. Probiotics, I think it's the Lancet trial, and of course, very close friend of mine, Hein Gojen, who is the one who started the Dutch pancreatitis group. And they actually had increased mortality, like you said. And the increased mortality is because these people have gut mucosal barrier gone and translocation. So one of the things is the patients died because of intestinal ischemia and gangrene. And so they said that when the gut mucosal barrier is destroyed, these probiotics go from there, and some of them have, the fungi and all, and they had septicemia and all. So at the present time, if the child comes with probiotic, you should stop the probiotic. Probiotics should not be given because we have a good level 1 evidence that they're bad. So that's the thing. Yes, doctor.
Yeah, thank you for the great talk. I was just wondering if you might make some general remarks about pain control in the setting of acute pancreatitis, whether there's a role for scheduled pain medicines or just using PRNs or PCAs, oral versus IV, just your thoughts.
Yeah, so this is once again a very important thing. So I didn't put everything in the talk because of the time. I just wanted to have 25-30 minute talk. So pain control is very important, and it's best to give them on a scheduled basis and not on a PRN basis, because 80% of the patients will stay only for 2 to 3 to 4 days and get dismissed. So in the first 2 days, giving them on a scheduled basis is better than PRN. If it is too much, you can choose PCA. Otherwise, every few hours, if you give, that's fine. Usually, either it's fentanyl or Dilaudid. That's what we choose. Morphine, we are not so much believing that it causes spasm of the sphincter of OD, exacerbate the pancreatitis. That's not the thing. But fentanyl and Dilaudid are better both for PCA as well as scheduled basis administration. And then quickly change it over to oral, and then dismiss the patient with few days of oral supply. That's what we should do.
One more question. Any role for following the lipase levels after the initial diagnosis?
No. Because the two things I want to tell you. People usually say it's not uncommon for residents or fellows to tell the staff, this patient has come with rip-roaring pancreatitis with lipase of 20,000. It has been clearly shown that once the threefold elevation is over, and if they say upper limit is 300 and you have 900 lipase, whether it's 900 or 20,000, there is no difference at all. Actually, as a matter of fact, the 20,000 patient may go in 3 days, and the 900 guy may stay for weeks and go into the intensive care. So the level of elevation has no correlation with the severity, and B, following it every day does not mean anything. And without being disrespectful, the surgical fellows will usually come and say that, we will operate the gallbladder after the lipase comes down or amylase comes down, or why are you feeding when the lipase is high, just keep doing. They have absolutely no basis. So you either for feeding or for operating, once you have made the original diagnosis of threefold, subsequent values do not dictate anything change in your thing. It's how the patient clinically behaves. That's the thing.
Thank you. That's it for us off-site questions.
One question about cancer and association with pancreatitis and how you approach those patients.
This actually is a very important topic, and it's a big topic that people are working on. So once again, coming back, 2 to 3% of acute pancreatitis, the cause may be underlying pancreatic cancer obstructing the pancreatic duct, increasing the pressure, and then causing pancreatitis. Then 2 to 3% of pancreatic cancers first present to you as acute pancreatitis. This is very important, and that's why in more than 50 you suspect them. And this is the reason that once the inflammatory changes subside, 6 to 8 weeks usually, you need to bring them back for endoscopic ultrasound, mainly, particularly if they're over 50, to see if there is a small cancer near the ampulla or somewhere obstructing the pancreatic duct. And they are so small during the acute inflammatory stage, the CT and MR may not be able to show that because everything is inflammatory thing. Do you do CA19-9 during this phase when you don't have any other cause? We don't have any evidence that a CA19-9 can make a good diagnosis because CA19-9 can be high in cholangitis and pancreatitis too. So that's not going to work. But there's another interesting thing. There are studies where they looked at what percentage of acute pancreatitis where cause is not known in the first 3 months or 6 months that subsequent diagnosis of pancreatic cancer is made. If you make a diagnosis in the 3 to 6 months period, then we know that that probably has caused the pancreatitis 3 months ago or so. But then there are studies now that are coming out that after an attack of acute pancreatitis, in the 1, 2, 3, 4, 5 year period, there is increased incidence of pancreatic cancer happening. So that's the second thing. One is pancreatic cancer, which caused that attack, which you will diagnose in the next 3 to 6 months if you diligently look for. But acute pancreatitis and the inflammatory process on the pancreas somehow seems to develop a pancreatic cancer subsequently in 3 to 5 years. So that's another thing too. So there are some studies, and actually we are looking at the Olmsted County database to see what proportion of people develop pancreatic cancer and why it happens. There are so many hypotheses, but yes, doctor.
You briefly mentioned about antibiotics. Could you tell us, when you electively use, and is it in moderate pancreatitis or not? Just the overview
Sure.
on antibiotics.
Sure. So once the patient passes 3 to 4 days period, now you know that this patient is falling into that 15-20%, is going to stay with you. Then you do a scan and then you say there is necrotizing pancreatitis. And in those people, if they start having fevers, chills, and clinically you suspect infection, sometimes it's hard to distinguish between the SIRS process, fever, leukocytosis, versus the actual infection. But when there is a doubt, we then say there is probably infection. We send off blood cultures and then start antibiotics. The type of antibiotics you have to start. In original days, we used to say ciprofloxacin and metronidazole. But now, as you all know, that ciprofloxacin is supposed to be a very dangerous drug. And, we are trying to take away our hands are cut now because we used to give Cipro and Levoquin for everything, even sneezing we used to give, but now we have to stop. So now we have to either, but while some guidelines say imipenem, meropenem, and your infectious diseases folks will come and say you have to police meropenem, imipenem, don't do it. So we are actually giving Zosyn quite often after the blood cultures. Then if they improve, then we don't intervene. We don't intervene at all for 4 to 6 weeks because we try to wait as far as possible unless they're really sick. So if they improve, then we can probably convert them into something oral if they are getting dismissed for a 7-day period. And that's what we do. Doctor, you have a question? Yeah, I'm sorry. Yeah.
Something that I think many of we residents, a particular challenge for us is managing alcoholic pancreatitis that goes along with some acute alcohol withdrawal on the inpatient setting. Could you just share some thoughts about how to sort of simultaneously manage both of those problems, how to understand, hemodynamic instability in the setting of ongoing withdrawal?
Yeah, so it's a good question because you do not know the tachycardia and other things. Is it because of a severe pancreatitis going on or is it because of withdrawal? So once again, we put them on the SEVA protocol and try to control them as quickly as possible. And then we have the imaging evidence too. Suppose if the imaging evidence is necrotizing pancreatitis and the patient, you are doing a good SEVA protocol and they are taking quite a lot of benzodiazepines and still they're not doing well and their tachycardia is quite high, then we think that maybe it's the pancreatitis that is causing the thing. But once again, We don't have any specific treatment for pancreatitis other than 24 hours of IV fluid. Subsequently, it's probably, if you suspect infection, antibiotics, then it's only supportive treatment. So that's the... Doctor?
Thank you. Given your comments on screening and given your comments on cancer following acute pancreatitis, is there any screening rationale that will develop down the line, given what we're doing with IPMNs now, for example?
Yeah, so it is possible, but at the present time, the subsequent cancer that happens, which are only few studies that have come out, we still do not have enough evidence to say this is the percentage of people who get cancer. So for any screening process, as you know, we have to satisfy those 6-7 check marks. The frequency has to be more than 12%. A. B, we have to have a screening test that is extremely sensitive and specific. C, it has to be cheap. D, it has to be safe. All those things. So we are still at number one. What's the actual thing? So, but if that number one becomes, 10-12% in these future trials, then obviously people will jump onto the screening thing like IPMN, like you're talking about. Yeah.
One more question coming from Grady. Is there any prognostic significance of a smoldering, mildly elevated lipase levels in patients with recent history of pancreatitis, say several weeks out with ongoing elevations?
So this is one thing, we strongly discourage them not to do any lipase, but then we can preach from the mountain tops, but you cannot make a change. So people keep on doing lipase, and then they keep on referring patients back 300 miles, 400 miles, saying that the patient has still twofold elevation of lipase. And when you see this patient traveling 300 miles, and then come, and the patient tells you that I have no pain at all, so then of course it's wrong. But the thing is, many of these patients, mild pancreatitis, after they get dismissed, for a variable period of time, 2 weeks, 3 weeks, 4 weeks, 5 weeks, 6 weeks, they will be having some pain. And the pain for some time requires narcotics. Then, they don't take narcotics, they limit their food and they're taking carefully, and eventually they become fine. So that's the course of a mild acute pancreatitis. So there is really nothing there. Some people tried to come up with smoldering pancreatitis, and then they said lipase of twofold elevation. And then they come up with some papers and they say that you have to include this in the classification. So I tell them those are normal acute pancreatitis. They take some time to recover. If you start doing more things, you will always find abnormality. Just to tell you one thing, there is a guy by name Gullo from Italy. He's in practices in Rome. So he went and actually went to a village, adapted the village, and did lipase on all people over 20 or 25 years. And then he found 3% of the people had elevated lipase. And in those 3%, about 50% of them had elevated lipase more than 3 times. They're people living in their village. They don't have anything. Then he followed those people with elevated lipase. First he did imaging on all of them. And almost all of them are normal thing, except 1 or 2 he picked up accidentally. Then he followed them for a year with every 3 months lipase elevation. So the lipases were going 5 times, then 2. So he came up with these things. In some people, just the lipase that we secrete maybe just leaking back into the blood. So he called it benign hyperlipasemia, or Gullo's syndrome as we call. So that's why doing lipase, other than what it is supposed to do at the time of diagnosis, will not tell us anything. And many people in California particularly, I'm sure you are knowing, Californians, particularly the movie stars and all, they want to live 200 years, so they want to do many things on their bodies to live for 200 years. They get a boutique CT scan from head to toe, and in the executive checkup, they do always a lipase and CA19-9. And so then you have CA19-9 of 1500. So those people keep coming. I'm sure you must have seen many. And you do all the things because it's a movie star, and then 1500, and you do. Everything is normal. And sometimes you find a small thing in the EUS because we are trying to dispel the doubt. And you put in a needle and they get pancreatitis now, and they get admitted this thing, and they have a nodule they found in the chest, they get a bronchoscopic thing, they get a pneumothorax, and then they bleed and they do this thing. So the important thing is, if you are fine, don't do too many things. More is not better, and that's high value care. So I don't know how this started actually, the whole thing. Lipase,
Smoldering pancreatitis.
Thank you very much.